afternoon, everyone. Welcome to our Wednesday noon seminar and discussion group that falls under the Global Development Program weekly seminar series, which doubles as a course that 4 different departments on campus offer credit for. So a good portion of the people in this room are students taking this course, and then we have people who are joining us online from various parts of the university, and a number of faculty and staff and so on. So we have, as usual, a nice diverse group. Welcome our speaker today, Dr. Shannon Monnat. And Dr. Monnat is at Syracuse University, and there she's the Learner Chair for Public Health Promotion, Director of the Center for Policy Research, Co-Director of Policy, Place, and Population Health Lab, and Professor of Sociology. Very much great time to come and be with us today, but we're really glad to have you here. Shannon is a demographer and population health scholar. His research examines trends and geographic differences in health and mortality, with a special interest in rural and health disparities. She's a leading national expert on structural and spatial determinants of drug overdose, and her most recent research is focused on geographic differences in COVID-19 experiences and impact. And so we're happy that Shannon will be presenting to us today on U.S. rural population health in the context of drug overdose, COVID-19, and longer-term mortality strategies. Shannon, the floor is yours. Thank you for being here.
Thank you, everybody. It's really a pleasure to be here. The drive from Syracuse is only about an hour, but it was lovely. Really enjoyed it. I'm from upstate New York, rural area, Lowville. So whenever they tell you to park behind the dairy barn, it feels like I'm right at home. I'm happy to be here. Thank you all for joining us. I'm going to present a few findings from my recent research on drug overdoses and COVID-19 in the rural context. But before I get into that, I really want to do it within the context of longer term mortality trends in rural areas. So let's spend some time on those first. Most of what I present is based on metro, non-metro county delineations, but I often use the term rural to really mean non-metro. Okay, so I use that interchangeably throughout the presentation. And when I show trends over time, it's important to note that I use consistent classifications for counties. And this is important because county classifications can change over time from metro to non-metro and vice versa. So I use a consistent classification of the 2013 definition when I'm presenting trends over time. So 3 questions drive my analysis of long-term trends. And I have these questions because I think that they can help us get at some potential explanations for what we observe here. The first is, when did the rural mortality penalty emerge and how has it grown over time? The second is, where are mortality rates high and rising, and maybe where are they declining? And the third is, which causes of death are contributing most to these mortality trends? And again, I think answers to these questions can help us start to get at some of the underlying explanations for what we see. So first, when did the rural mortality penalty emerge and how has it grown over time? Well, as you can see from these charts, the penalty isn't new. It emerged in the late 1980s for males and early 1990s for females. And what's really striking is the growth in the gap over time, with especially large increases in the 2010s. And that longer term context is really important when trying to think about the underlying explanations for the gap. For instance, we might be curious about why the gap started to grow so much during the 2010s and why whatever happened then disproportionately affected rural areas. Your eye, of course, is probably drawn to the end, that massive growth in mortality rates in 2020. Mortality rates surged in both metro and non-metro areas in 2020, and they continued to do so, but the rates increased slightly more in 2020 in non-metro areas than in metro areas, so the rural penalty widened even more and will in fact continue to do so. Among non-metro males, COVID-19 wiped out 20 years of gains in mortality. And among non-metro females, it's wiped out over 40 years of improvements. So a pretty big deal, right? And COVID mortality rates have continued to increase in 2021 and 2022, and they're increasing more in non-metro areas and in metro areas. So again, the gap will continue to grow. Mortality rates are higher in rural than in urban areas across every age group, but the gap has increased for different reasons in different age groups. So among older adults on the right, the gap has increased because metro mortality rates have declined more than non-metro mortality rates, right? In general, the story has been one of improving mortality among that older age group, but it's just that mortality rates have declined more among metro older adults than among non-metro older adults. But among working age adults on the left there, the gap is increased for two different reasons. The first is that metro mortality rates continued to decline throughout the 2000s, but they held stagnant for non-metro working age adults. And then by the 2010s, while metro rates were still declining or had leveled off and had remained stagnant, non-metro rates actually began increasing, okay, which is sort of unprecedented in terms of the long-term trends. These working age adults are an especially concerning age group for US mortality trends because this is the group for whom mortality rates are increasing in the US over the long term. And this is the group that has contributed most to the US's diverging life expectancy relative to our peer countries, our high income peer countries. So I focus on this group in the next couple of slides. Understanding where rates have increased for working age adults can also clue us into the structural drivers. And so here I focus on changes since 1990, since that's really when geographic disparities in mortality started to increase. These maps show absolute changes in mortality between the early 1990s and the mid 2010s. Males are on the left, females are on the right. Ages 25 to 44 are on the top and 45 to 64 on the bottom. The red shaded counties are places where mortality rates increased over this period, okay? And you can see that while urban coastal cities have generally experienced large declines in mortality in these age groups, rates have really surged in parts of America's heartland, and that's rural areas and small cities alike. These are places that were once hubs for secure working class jobs in manufacturing and mining. You can see the increases have been really large in central Appalachia, New England, the central US, parts of the Southwest, the Mountain West. This too might help us think about underlying drivers, right? Why these places? Mortality rates, the increases you can see here were especially widespread and especially pronounced in the younger age group and among women in both age groups. And these large and widespread increases among women I think are especially startling. Understanding which causes of death are driving the rural mortality penalty can also help us understand structural drivers. And before I orient you to these figures, I just want to note as a baseline that mortality rates are higher across almost every cause of death in non-metro areas than they are in metro areas. The exception is for drug overdoses, which have surged, especially recently, much more in urban areas, particularly for years that aren't included in these figures. These charts show changes in mortality for 15 specific causes of death between 1990 and 2018. So this is pre-COVID. These charts are for metro and non-metro males, ages 25 to 44. And what I'm doing here is decomposing the changes in mortality rates by decade. So the different shading in these bars represents the decade in which the change occurred. The lighter colors, light green, light orange, means the change occurred in the 1990s. Green means a decline in mortality rates. Orange means an increase in mortality rates. The middle shades represent the changes that occurred in the 2000s, and then the darkest shades represent changes in the 2010s. Okay, so the temporal changes, I think, are really illuminating because throughout this series of figures I'm about to show you, I want you to notice that for the causes of death that declined, almost all of that decline happened in the 1990s and then in the 2000s. For any cause of death that's declining, that's not happening at all in the 2010s. And for causes of death that are increasing, they're increasing a lot in the 2000s and 2010s, not the 1990s. So the takeaways from this figure, we can see that HIV/AIDS accounted for the biggest decline in metro male mortality rates in this age group. And this is partly because mortality rates from that cause were much higher among metro males than they were among non-metro males in the 1980s and 1990s. The progress that's been made in reducing that cause of death has been pretty massive and has contributed to bringing down the overall metro male mortality rate in this age group. For the other causes of death that have declined, they've declined much more in metro than in non-metro areas, as you can see from the green bars. Some causes of death have increased in this age group. Again, that's the orange bars. You can see that increases in drug poisoning were comparable in this age group in metro and non-metro counties. Rates increased a bit earlier for non-metro males than they did for metro males, but the overall increase in this period was pretty comparable in this age group. And except for drug overdoses then, non-metro young males experienced larger increases in numerous other causes of death. Endocrine, nutritional, and metabolic diseases, these are things like diabetes and obesity-related causes, okay? Alcohol-induced deaths, suicides, respiratory diseases, and other causes. This shows the same set of figures for young females, 25 to 44, and here we see similar patterns, but we see increases in even more causes of death over this period, with especially large increases for non-metro females. Non-metro females did experience larger increases in drug overdoses than metro females. So in that case, drug overdoses did contribute to increasing the non-metro mortality gap for these young women. They also experienced larger increases from every other cause of death that increased, as you can see by all of those orange bars there on the right. I want you to notice these increases in metabolic, hypertensive, and ischemic heart diseases. These are young women. This shouldn't be happening in this age group. This is not the age group that you think of when you think of heart disease or diabetes deaths, right? These deaths are driven by increasingly obesogenic environments. And you notice that this is happening much more among non-metro females than it is among metro females. This shows the same set of figures for men, 45 to 64, and we can see that mortality rates have actually declined in this age group for both metro and non-metro males. And this is due to really massive declines in lung and screenable cancers and in ischemic and circulatory system diseases. Fabulous inroads, improvements in medical treatment technology, pharmaceuticals that helped bring down these causes of death in both metro and non-metro areas. But for each of these causes where mortality rates have declined, they've declined more among metro males than among non-metro females. And then there are also several causes of death where mortality rates increased. Again, those orange bars. You can see mortality rates increased across more causes of death among non-metro males than they did among metro males. And for every cause that increased, with the exception of drug overdose, they increased in both groups. They increased more among non-metro males. And you can see the patterns start to unfold here. Mortality rates are increasing at more causes of death and at greater rates among non-metro than among metro. And then finally, among females ages 45 to 64, we see smaller non-metro declines in lung and screenable cancers and in ischemic and circulatory system diseases. Mortality rates, again, from more causes increased among non-metro females. And again, for the causes that increased in both groups, they increased more among non-metro females, including drug poisonings, but also alcohol-induced causes, suicides, mental and nervous system diseases, infectious diseases, respiratory diseases, and other causes of death. And for many of these causes of death that increased, like respiratory disease and metabolic diseases and suicide, we can see really pronounced increases in the 2010s. I don't know, does this work? Oh yeah, it works. So again, right? So you see these increases in the 2010s in a lot of these causes of death, but you don't see many declines in the 2010s, these dark green colors for the causes of death that were declining throughout the last couple of decades. So the takeaways from this general overview of these trends is that the rural mortality penalty is wide, It's growing. It exists across all age groups. It's happening among both males and females. I don't show here. I have a separate set of figures that show that it's also increasing across all racial ethnic groups. Okay. The gap is widening most for non-Hispanic whites, but it's also widening for Blacks and Hispanics and American Indians. And it's widespread. It's happening across multiple disease categories, injury categories, causes of death, including causes that shouldn't be affecting younger adults. The gap started to increase in the late 1980s and early 1990s. That was due first to larger mortality declines in metro areas, but then later, due to stagnation and mortality increases in non-metro areas. We see the gap across several regions of the US, but some places are doing better than others, as we observed in those maps. And the gap is driven by nearly every cause of death. So then, how might we understand the rural mortality penalty? If mortality rates are increasing across multiple causes, they're increasing across every demographic group. That suggests that there's not one underlying cause, one underlying explanation, right? Instead, we can point to failures across a wide array of systems and institutions that start at the top level here, these social, political, cultural, macro, structural causes, and trickle down to affect the proximate causes of mortality. So for example, if we take the healthcare system, healthcare availability or quality, which would be at this community meso level, that has a major influence on certain causes of death, like screenable cancer, right? And we certainly wanted hospitals to be around and functional during COVID-19, for sure. And thanks to improvements in technology and screening, the US has really made impressive inroads in reducing screenable cancer mortality, to be sure. We saw it in the green bars. So geographic differences in causes of death, like screenable cancer, might reflect geographic disparities in healthcare availability and quality. And we know that rural hospitals are under-resourced and they're not even existent in some rural areas. But why do so many people continue to get cancer? Healthcare can prevent you from dying from cancer. The healthcare doesn't cause cancer, right? In fact, healthcare isn't the primary driver of most causes of death. Well, what about health behaviors? Health behaviors are down here. They're this individual proximate category down here. Respiratory disease, lung cancer, drug poisoning, cardiometabolic diseases. These all reflect behavioral factors. Include smoking, obesity, alcohol and drug use. Rural residents are more likely to smoke. They're more likely to be obese. They're less likely to engage in physical activity and a whole array of other poor health behaviors that we know increase the risk of dying young. Well, why? It's partly due to lower educational attainment, which is also down there at that individual proximate level. But we know, and we know that educational attainment is lower in rural areas. So maybe that kind of has something to do with explaining differential health behaviors. But why does education matter so much for health in the US compared to other countries? And why does education seem to matter so much more in some contexts in the US than in others? Well, I think if we move upstream, we can really start to think much more critically about how geographically variant policy choices matter in ways that affect both things that are happening down here at this level, like, for example, healthcare, and things that are happening at the proximate level, like, for example, socioeconomic status or health behaviors. For example, although smoking is a behavioral risk factor for several causes of death that we saw, contribute a lot to midlife mortality, individual level explanations are sort of unsatisfactory if we consider that geographic trends in smoking related mortality can be explained by different state level policy choices related to tobacco taxes and smoking in public places. So states that have higher excise taxes on tobacco, holding all else constant, have lower mortality from tobacco-related causes of death. Okay. And there are numerous examples of this, from labor policies to gun policies. And while today there's too little time for me to try to attempt to explain the rural mortality penalty and tease out the role each of these factors might play, I do think the upstream avenues deserve a lot more pursuing. And I'm going to show you some hot off the presses research to set up one way that we might think about how policies could be contributing to the rural mortality penalty. And when I say hot off the presses, this paper is being published today at 2:00. Okay, so like just over an hour from now. This is a paper led by my colleague, Jennifer Karras-Montes at Syracuse University. And in it, we model associations between 8 state policy domains that capture 57 different policies and working age mortality rates from 1999 through 2019. I'm going to walk you through this, okay? We looked at mortality from all causes of death, and then we looked at the role of policies on the types of death that are driving midlife mortality trends: cardiovascular causes, drug overdose, alcohol-related causes, and suicide. Each state is assigned a score on their policy domain, policy regime, ranging from 0 to 1. A score of 0 means that that state has the most conservative policy orientation on these domains. A score of 1 means the state has the most liberal or progressive orientation on these domains. So just as an example, if you take gun safety, a score of 1 would mean that the state has the most restrictive gun safety, the gun laws that you can think of that try to, reduce the purchase of guns and, reduce the number of gun-related deaths that might occur from that. So what happens in this analysis is that we find that state policies were very important for understanding between state differences in mortality trends. This figure is showing the estimated percentage difference in all-cause mortality among women. The blue circles are cases where a more liberal version of the policy reduced mortality. Okay, the red circles are cases where a more liberal version of the policy increased mortality, or if you flip that, a more conservative version of the policy reduces mortality, okay? What you can see here is a pretty clear pattern that for most of these policies, more liberal versions at the state level are associated with lower all-cause mortality rates among females, okay? The 6 different dots, by the way, are lags between the year the policy went into effect and the year we count mortality or observe mortality, okay? So like this is 1 year, the policy went into effect, and this is the mortality rate. This is 6 years out from when the policy went into effect and when we observe mortality rates, okay? So for women, we found that more liberal versions of criminal justice, environmental, gun safety, labor, economic tax, and tobacco tax policy are all associated with lower mortality rates. And more conservative versions of marijuana policy are associated with lower mortality rates. It's the same figure for working age men. We see a very similar pattern with the same group of policies: criminal justice, environmental, gun safety, labor, economic tax, and tobacco policies, all being associated with lower all-cause mortality among men. When we examined cause-specific mortality, we found that cardiovascular disease mortality is lower in states with more liberal policies on gun safety, economic and tobacco taxes, the environment, criminal justice. Alcohol mortality is lower in states with more liberal labor policies, criminal justice policies, and economic tax policies. And suicide rates are lower in states with more liberal policies on economic taxes, gun safety, criminal justice, and labor. Okay, pretty robust pattern, consistent across numerous policy domains and numerous causes of death. We ran model simulations on hypothetical policy scenarios. For example, what if we set all states to the maximum liberal policy orientation or the maximum conservative policy orientation on all 8 of these policy domains? We found that if we changed all states to the maximum liberal policy orientation, that it might have saved over 171,000 lives in 2019. Conversely, if we set all states to the maximum conservative policy orientation, that might have cost over 217,000 lives in 2019. Now, of course, no state is at the max liberal and max conservative, right? So these are hypothetical scenarios. So why might this be related to rural mortality trends, right? I've showed you nothing at all related to rural yet. Well, maybe it could be because policy orientations have diverged between more urbanized and less urbanized states since the 1980s, with more urbanized states implementing more liberal policies and less urbanized states implementing more conservative policies. What this means is that rural residents are increasingly living in policy environments that, according to what I just showed you, increase their risk of premature mortality. We haven't done the causal research yet to connect policy divergence to rural mortality trends. So this is just speculation. But when you think about when these state policies started to diverge in the late 1980s, and you recall back to the beginning when I told you that the rural mortality penalty really started to open up in the late 1980s and early 1990s, there's at least correlational evidence that state policy environments might have contributed in some way to the widening rural mortality penalty. So this is an area that we plan to pursue going forward. So let's change gears. That's the overarching trends in rural mortality rates. And now that you have that broader context in mind, I want to talk briefly about some of my research on drug overdose in rural areas. So take a look at the national trends first. There have been over 1 million fatal drug overdose deaths in the United States since 1999. And the primary contributor for sure has been opioids. Those are the red lines. But deaths involving cocaine have increased, psychostimulants with abuse potential, which is methamphetamine, have increased, and prescription benzodiazepine-related overdoses have increased. And that really highlights for me that our problem is bigger than opioids. Just as one example, methamphetamine-involved deaths increased over 50% between 2019 and 2020. And meth is now the second largest contributor to overdose deaths after fentanyl, synthetic opioids. And they're actually the primary contributor to overdose deaths in the West. And they're also involved in a larger share of overdoses in rural places than in urban places. And so what I want you to take away from this, really two things. One is that the drug overdose crisis remains a really huge problem, even though COVID has kind of captured our attention. But also our problem is bigger than opioids. This is not an opioid crisis. It's an overdose crisis involving multiple drugs. Now, a common media narrative about the overdose crisis a couple of years ago was that it had disproportionately affected rural communities. Headlines like these were painting a nearly monolithic picture of a rural America in crisis. And to be sure, that coverage led to much needed attention and resources to downtrodden rural areas that certainly needed it. But it also misrepresented the geography of the overdose crisis and ignored widespread heterogeneity in the severity of the problem across different rural areas. Overdose rates were higher in non-metro counties overall only in the late 2000s and in the early 2010s. Prior to the late 2000s, rates were higher in metro counties. And since the emergence of fentanyl, rates in metro counties have again surpassed those in non-metro counties. But metro status categories are arbitrary, somewhat arbitrary, as I'm sure you've talked about in some of your classes. So if you take a look at the map, what you can see from the map is that some rural places have among the highest overdose rates in the whole country. Appalachia, New England, some of the desert Southwest. Meanwhile, other rural counties have among the lowest overdose rates in the whole country, the Mississippi Delta, the Great Plains, parts of Texas. And so aggregating rural counties into a single rate averages out large differences across these different rural regions and economic contexts that really seem to matter. So it's not rurality so much that matters. It's the living context in these places that have high overdose rates. This figure shows the percentage difference in the fatal drug overdose rate for a 1 standard deviation increase in the predictor variable. Okay, so the red bars are county level factors that are associated with higher overdose rates, and the blue bars are factors associated with lower overdose rates at the county level. And we can see that in addition to supply factors like opioid prescribing, and now fentanyl, which is not included in this study because it was really pre-fentanyl, factors that reflect economic and family disadvantage and concentrations of certain kinds of industries are playing important roles. Overdose rates are higher in counties with more economic disadvantage, more separation and divorce in single parent families, and a higher share of jobs in mining and retail and services. Rates are lower in counties with a larger share of jobs in farming, fishing and forestry, manufacturing, finance, and professional occupations. And these aren't just current associations, okay? These particular predictors I'm showing you here are from the 2000 census, okay? But in this paper and in others, I showed that these same factors using the 1980 census data are associated with higher overdose rates during this same period, the 2000s and 2010s, okay? So this isn't just a recent manifestation, it's a long-term trend. That was quick because I want to have time to discuss COVID, because that's the big thing right now, right? But my takeaways from this line of research are that our problem is bigger than opioids. We have to move our attention beyond this seemingly singular focus on opioids to the broader issue of why so many people in so many places are engaging in harmful behaviors or are feeling the need to self-medicate. My concern is that an overfocus on opioids will mean that we'll impose policies that target specific drugs rather than the underlying cause of drug use initiation and harmful use. Another takeaway is that drug overdoses aren't disproportionately rural, but they are higher among rural females than rural males. Males have higher drug overdose rates than females, right? So when you look at the aggregate trends that combine males and females, they're gonna cancel out the females really because they have so much higher overdose rates. They dominate the overall trend. But we need to keep in mind rural females do have higher overdose rates than urban females. In addition, some rural areas have been severely impacted, much more than others. And this is not necessarily a function of rurality, but it's a function of things like county level economic disadvantage, family structure, industry structure, and how those all contribute to between county differences in drug overdose rates, even holding supply level factors constant. So I think that understanding this mess that we're in really requires that we come to grips with long-term economic and social decline and the policy failures that drove that decline. So let's switch gears again now and talk about COVID-19. Back in March 2020, I wrote a brief predicting that COVID-19 could hit rural areas harder than urban areas. And at the time, I think people thought I was a little nuts. COVID was almost non-existent in rural areas. All attention was on big cities. You guys think back, remember this, right? But I argued that various aspects of rural places made them vulnerable to COVID should it actually spread there. This included things like their older and sicker population composition and contextual characteristics related to more limited healthcare infrastructures or differences in labor markets that packed people together closely and didn't really allow for work from home. By late summer to early fall of 2020, cases and deaths started to increase at a faster pace in rural areas. And by December 2020, COVID-19 mortality rates were higher in rural counties than in urban counties. What I didn't anticipate so strongly, or had an inkling, but was a little hesitant to put it in this brief, was the role that Trump and partisanship and resistance to protective behaviors and vaccination would play. And it turned out that they were really important, as you'll come to see. COVID-19 mortality rates, as I mentioned, were higher in metro areas during most of the first year of the pandemic, but by December 2020, that pattern had shifted. And since then, non-metro rates have taken off and the gap has continued to grow between metro and non-metro areas. On December 13th, 2020, the CDC recommended vaccines for all adults in the US. And recall, up until then, they were mostly available only for older adults, frontline workers, the immune compromised. My graduate students and I did some analysis to examine rural-urban differences in adult vaccination rates as of August 11th, 2021. That's about 8 months for people to get vaccinated from the time the CDC said, go wild, everybody is eligible, everybody should get a vaccine. And by that point, 60% of metro adults had been fully vaccinated compared to 46% of non-metro adults. We examined vaccination rates across the full rural-urban continuum in a paper that we published in the Journal of Rural Health. This shows the differences in vaccination rates between RUCs 2 through 9. So large urban is the comparison group. And you can see that medium and small urban counties and all of the non-metro categories had significantly lower vaccination rates relative to the largest urban counties. These bars here show unadjusted vaccination rates, but once we start adding predictors to these models to figure out why these groups seem to have lower rates relative to large urban, we found that that difference was entirely explained by two things: differences in educational attainment and Trump vote share. Okay, so rural areas have lower educational attainment on average, and a higher share of the 2020 presidential vote went to Donald Trump. Those two factors alone explain the non-metro difference in vaccination rates at this period. And just to highlight the role that Trump vote share played, here are average county vaccination rates. This is for the whole country, not just non-metro counties. These are vaccination rates across the categories of 2020 Trump vote share. And you can see a clear pattern here, right? As Trump vote share increases, vaccination rates decline. So in our next paper, we looked at rural-urban continuum differences in mortality rates from COVID-19. And these were mortality rates as of October 1st, 2021. And here we see at this point, again, higher mortality rates among non-metro than among metro counties. These rates capture the full COVID-19 period from the beginning up until about the middle of the Omicron Delta wave, to just kind of give you some temporal context here. And we found that in the case of these mortality rate differences, the rural disadvantage was really explained by lower median household income and lower educational attainment in rural areas. So I'm going to bring you back to this figure again to highlight how the gap really opened up during the Omicron Delta wave, right? Our initial study that I just showed you captured rates up until October 1st. That's this little red dot here. But the gap was tiny then compared to what happened after. So let's see what's happened since. In a study that's led by Malia Jones at University of Wisconsin, we're currently examining rural-urban continuum differences in the Delta Omicron wave. Okay, so it's a restricted period of time, this period that's grayed out here. So this spans from about mid-June 2021 to mid-March 2022. These bars show the difference in mortality rates for each of the RUC categories compared to large metro. And RUC 1 is large metro. And you can see that each category has a significantly higher mortality rate than large metro. These little stars represent a statistically significant difference, okay? So this model has no controls. Then we add controls for the pre-Omicron Delta wave case rate and the COVID-19 vaccination rate. So we add two variables to these models. And you can find that adding these two variables, the pre-Omicron case rate and the vaccination rate, attenuates the difference quite a bit. These gray bars show you where the difference was. The orange bars show you how much the difference has declined since we added those two variables. But the differences are still statistically significant, okay? So each of these categories still have significantly higher COVID-19 mortality rates than large urban. We then add age composition and the pre-COVID all-cause mortality rate. These are proxies. They capture the older adult population that has a greater risk of fatality should they get COVID, and they capture sort of pre-existing health conditions at the county level, and they have a really big effect. So we see that this large attenuation in these non-metro categories, right? And this isn't surprising thinking about the much older and sicker age composition and sicker composition in non-metro counties and how that puts them at higher risk of death of COVID should they contract it. We then add socioeconomic and demographic factors. Okay, and here's where things get even more interesting. So the addition of socioeconomic status, especially poverty and educational attainment, and demographic characteristics, especially the non-Hispanic white population share, completely eliminates any additional rural disadvantage that we saw from the last model. And it actually flips the direction of the difference, okay? We know that poverty and education are strong predictors of COVID-19 mortality rates, right? We've known this for months. And remember that during the Delta Omicron wave, mortality rates were actually higher among whites than they were among Blacks and Hispanics. Even though COVID started out with much higher mortality rates among Blacks and Hispanics, by the Delta Omicron wave, that had flipped. And COVID mortality rates were much higher among whites. So the implication here is that if small metro counties and non-metro counties had similar non-Hispanic white shares, meaning lower non-Hispanic white shares as large urban counties, and if they had similar poverty rates and educational attainment as large urban counties, they would actually have lower COVID-19 mortality rates. Right. So when we add these variables to a model, it's holding those factors constant. So it's partly because rural counties have more whites, a larger share of whites, higher poverty rates, and lower educational attainment, that their COVID-19 mortality rates are so much higher relative to large urban counties. When we wipe that out, if we were to hold all that constant, they would have lower mortality rates than large urban counties. Finally, we add Trump vote share. And Trump vote share doesn't make much difference at this point in the model. It does increase the magnitude of the RUC 8 and 9 coefficients a bit, with the implication here being that if they had similar Trump vote shares as large urban counties, their COVID mortality rates would be even lower than what we saw in the last figure, holding all else constant. But we think that this is because the model already includes the pre-wave 4 case rate, and it includes the vaccination rate, right? So Trump influence is already baked in through those variables. Because, again, Trump voters, remember that I showed you earlier, counties with larger shares of Trump vote had much lower COVID-19 vaccination rates than counties with lower shares of Trump votes. So it's not that Trump vote share doesn't matter for the rural COVID disadvantage, but we believe it's operating through the behavioral factors that are already baked in through the pre-Omicron case rate and the pre-Omicron vaccination rate. In fact, in the fully adjusted model, a 1 standard deviation in the Trump vote share is associated with an increase in the mortality rate of almost 123 deaths per 100,000. And that's across all counties. Okay. And then in terms of, like how big is that effect size? What does that really mean? Well, it's actually comparable to the effect sizes for the share of college graduates and the poverty rate. Okay. So 1 standard deviation increase in those variables are associated with 100 death per 100,000 decline and 141 death per 100,000 population increase, right? So pretty comparable in terms of the role Trump vote share has played. So the takeaways from this line of research, COVID-19 is likely to exacerbate the existing rural mortality penalty. The rural COVID disadvantage has many explanations, but our research suggests that the older age structure, lower socioeconomic status, especially educational attainment, and greater support for Trump have played outsized shares in driving the rural COVID mortality penalty. And the rural COVID disadvantage it has important implications for a wide array of demographic and population health and economic and political outcomes that we might really be interested in and care about. So I think this is a wide open area for research for the next many years. As I wrap up, I just want to draw your attention to the Lerner Center's Population Health Research Brief Series. This is a series that aims to disseminate findings from faculty and graduate student and even undergraduate student research in really short, easily digestible, accessible formats. They're like 1 to 6 pages. So, like who wants to read a 40-page research paper? Really? Like some of us, but sometimes you just want to know what somebody found really quickly. That's what these briefs do. We have almost 200 briefs on various population health issues, ranging from rural, urban, and racial ethnic differences and various health outcomes, to the impacts of different policies on health and much more. Pretty much everything you could think of is in there. These are great to use as assigned readings in classes if you happen to be teaching classes. They're great to use if you have to write a paper and you want to start getting a sense of what's going on with some outcomes. So I encourage you to check out the Surface page. You can see all of our briefs. You can also sign up to get them in your email pretty much every week. So I'll just wrap up by acknowledging the funders of this line of research, who I appreciate very much, and I'm happy to take any questions. Thank you for listening.
Thank you so much, Shannon. That's fantastic. I'm an online question. So I want to pay attention to the fact that we do have some online participants, and so we'll begin with questions here in the audience. And as questions may come in, from our online sources, we'll pay attention to those too, but, I'm happy to run around with the microphone if we need to. So any questions or comments? Shannon, we'll see how the voice carries before I go through the microphone around.
Yeah, I should be okay. So the mortality rate in the beginning of your first graphic, which is the rate increase from 2018 to 2022. And so there might be multiple reasons for that. And then it shows this decreasing trend. And then you're saying that it may affect that decreasing trend, but the survivability in the coming years may also increase. Because we went through a period of time where, for instance, people could visit doctors, internet and dirty drugs. So there's a whole number of factors that swing statistics in that area. So addressing that statistic.
Do you mean in terms of the cause of death?
Yeah, for the overall mortality rate increases,
Yeah.
the rate surge like that.
Yeah.
And then when you break it down into all the statistical implications of what may cause that, the big swing in drugs,
Yep. Yep.
and some other health aspects.
Yep.
There's a period of time where people couldn't go and visit doctors, so that has a statistical impact.
For sure.
You have the introduction of fentanyl.
Yeah.
As a problem, that's a problem to the statistic. And then overall, you should see survivability increase in the next couple of years. So
Yeah.
really, you have this anomaly that you have to account for that trend.
Yep.
How are you going to account for that anomaly?
Yeah, it's a great question. So for people who didn't hear it, numerous causes of death may have increased in 2020, 2021, 2022, not just COVID, but we could have seen increases in things like cancer and heart disease mortality because people weren't able to visit the doctor. There were certainly massive increases in drug overdose. We've seen the surge, I think, over 100,000 drug overdose deaths already this year. Okay. And that's compared to what the peak was when we last have data, 77,000 in 2020, right? So those certainly increased. So how do you account for that? An analysis. And then is there the possibility that mortality rates could decline in the coming years because the people who are at greatest risk of dying have already died, either from COVID or from their pre-existing conditions that weren't treated or from drug overdoses? I think that's a perfectly reasonable speculation. And I think that demographers who track and disaggregate causes of death over time are going to have to, what they're doing right now is using the excess mortality rate to try to identify what's going on. So rather than relying just on COVID deaths, they're saying, how many more deaths did we have in 2020 or 2021, for example, compared to what we would have expected had trends from like the last 5 years remained the same in 2020 or 2021? Then they're saying, okay, well, what share of those were actually denoted as COVID deaths on the death certificate? Well, a lot of them, right? A lot of the deaths that happened in 2020 and 2021 and 2022 are COVID deaths. Then you can start to use the death certificate data to figure out how much of that increase, that excess mortality we saw over the last several years was due to like drug overdoses. How did that trend increase relative to the increase it's been showing over the last 5 years? But some of that in particular is unpredictable because of fentanyl, right? The outsized role that fentanyl has played on drug overdoses has just, I hate the word unprecedented because we keep using it to talk about COVID, but it really is like mind-boggling how much of a game changer fentanyl has been for drug overdoses. And then I definitely think that we're going to start to see some of the kind of selection effects, for lack of a better term, of people who were at the highest risk of death have already died. So we might see this actual large decline in mortality rates, 2 or 3 or 4 or 5 years from now. And we'd be like, well, we fixed the problem. Well, no, the people who are at the greatest risk just happen to die earlier than what they would have died if not for COVID. But yeah, demographers have like fancy decomposition tools. I don't do that kind of analysis, but they do that kind of analysis and they can tell you exactly what percentage of the increase or decrease over time is attributable to each specific cause of death.
And one follow-up question.
Sure.
Speaking on the spatial maps,
Mm-hmm.
and they were showing the rural drug use in central United States. I noticed that they adjusted for age,
Yeah.
but did they adjust for the spatial population. So they're looking at population and age, but spatially, where you're showing an actual decrease on one image or one graphic, those populations may only be 1 million people per state. Your Dakotas, Montana, New Mexico. So maybe in that instance, if you don't adjust for some spatial area or per population, you wouldn't be able to properly color that map across.
So just to make sure we're talking about the same thing, these are mortality rates. So then the number of deaths per population, right? So in this case, per 100,000 population. So they do adjust for population size. Is that what you're asking?
Yeah.
Okay. Yep. Yeah. And then in some other research, we've actually done some spatial modeling to see if there are like spillover effects, which is the other way that we could go with your question. Because, you know, you might imagine that a county that has a high overdose rate, that the conditions that created that, for example, supply, would spill over into their neighboring counties. And in fact, that does happen. So there are these kind of clusters of places that have higher than predicted overdose rates than what you would see on average across the country. And that's partly due to these spillover effects across different areas, which are more likely to occur in high density areas because there's just more commuting. It's easier and quicker to be able to get to dealers or dealers to get to customers, right? So, and that's partly why supply seems to matter so much more in urban areas than it does in rural areas, because the market is just so much bigger in urban areas. You can get like any drug that you want. In a non-metro area, like the dealer might not have every single different thing. So, you know, this is part of why I argue we can't just be focused on supply in one specific type of drug, because people will use whatever is available to them, right? So where there's demand, dealers will find a way to meet that demand. It just might be with a different drug that happens to be available in that geographic location.
You could get those 2 questions and then these questions in this row, and then we'll call it quits.
In the COVID results, you find that once you incorporate the other contributing factors of socioeconomic status, that Trump effect, whatever you want to call it, pretty much goes away.
Yeah.
So my question goes back to the first third results on withdrawal mortality, or the distinguishing between liberal and conservative policy. I'm just wondering, the same thing. You incorporated a lot of those socioeconomic and spatial and other types of factors. I'm wondering if that political dimension might also go away, because the chances are of it being highly correlated, negatively or positively, with a lot of these factors, I think, quite significant. Once accounting for those, I'm guessing that a lot of that political effect, or the importance of that political effect,
No, it doesn't.
really?
So we do account for those. You probably didn't see like the bright orange I had at the bottom that said this includes a ton of covariates and sensitivity checks. So we account for demographic and socioeconomic characteristics of these states. That's not what's explaining why states that have moved toward more conservative orientations have also seen increases in their mortality rates. It's not a function of the population composition or the socioeconomic composition of the states. There's something about those policies.
And let me follow up quickly.
Sure.
With a related question, which is, anytime you sort of take variables and code them the way it sounds like it did, there's inevitably some arbitrariness that enters the picture. And I'm just wondering, there are some alternative ways of looking at those policies rather than just this coding being did, to try to disaggregate them more, try to get a use of variables that are somehow more less sensitive to arbitrary characterization.
What do you mean by arbitrary?
Well, I just, having done this type of work for a long time, but there are a lot of judgment calls. I'm just wondering if you can somehow substitute some very specific quantifiable factors for some of those policies. Maybe
I guess I'm not clear what you're asking. Could you mean a specific example of what you're trying to get at? Do you mean like pulling out one policy from the overall domain? Is that what you're?
Each of the policies,
Uh-huh.
trying to specifically, or more specifically characterize what that policy means. So for example, health
Mhm.
could be, is it the per capita devotion of state level financial resources?
Yep.
Is it the presence or absence of multiple insurance companies?
Mhm. Mhm.
I don't know what, this is my area of work, so I don't know what the specifics might be, but I'm just wondering if you can get down to what you want to find.
Yeah, well, economists have done that. I mean, economists' whole field is to pick one policy and try to figure out the role of that one policy on causal change in some outcome. Part of the point of this research, the one that's coming out in like 40 minutes, is that people don't live in one policy. They live in bundles of policies. Think about your commute here today, however you got here, right? You were on some kind of a road, maybe. How many policy regimes are you under on that road at that time? You've got a speed limit. You've got whether the cops are allowed to be there at any particular time. And which cop is it? Is it the state trooper? Is it some other cop? You've got DUI laws that vary across states in terms of the legal limit. That's just three that I came off the top of my head, right? We live in multiple policy contexts at the same time. And so actually isolating one policy and trying to like figure out like, is it this one thing doesn't reflect the reality of people's lived experiences. And that's the whole point of this, is trying to figure out like, how do these policies bundle in ways that seem to have these big picture influences on overall trends that we have observed over time.
So I'm going to single out one policy.
Can you
I
speak
can.
louder? Maybe stand up.
Okay, I'm going to single out one policy. That's what was interesting to me. Was because I come from a country which is not dependent, like the health public that's not dependent on insurances.
Yeah.
So what is the scenario of health insurances between like non-metro and metro areas? Because irrespective whether it's drug overdose, COVID, or any other form of diseases, it is heavily dependent on the whether the person has an insurance or is covered by insurance. So I was just wondering how was that?
Rural counties have lower insurance rates than urban counties, and it's been like that for a long time. And moreover, in addition to that, it's not just that they have less access to healthcare because they have lower insurance rates. It's also that healthcare is just less available in rural areas than in urban areas. I think something like 150 rural hospitals have closed since, do you know the date, like 2006 or something? In the last, 15 years, over 150 rural hospitals have closed. And COVID is going to, exacerbate that too, because rural hospitals lost a lot of money. So clearly healthcare is really critical for certain causes of death. If you get sick, you want healthcare to be there, no doubt. But healthcare doesn't cause disease, which is what I mentioned earlier, right? So one of the biggest problems of public health in this country is that we try to treat problems after they already exist rather than preventing them to begin with. What if have you guys heard the river analogy? Everybody heard this river analogy? Maybe once I start saying it, you'll remember.
The babies.
I don't know if it's one of the babies. It's really morbid. So there's this analogy where there's this doctor standing by the shore of this swiftly flowing river, and he's standing there having a great time. And then he hears a cry for help, and he has to rush in, grab this person, pull them out, do CPR and save them. And just as he finishes up with this one person, then he hears another cry for help. And so he dives back in, gets this other person, and he pulls them out. And again, over and over, he's pulling people out, saving them. And he says, I'm so busy trying to pull people out and save them that I don't even look upstream to see who the hell is throwing them all in. And that is healthcare and public health in this country, right? We treat problems after they exist. We try to save lives when the problem is so dire that it ends up costing a lot of money. It costs a lot of lives. It's inhumane. What if we took a step back and tried to figure out, wait a minute, why are there so many people getting sick in this country? Why do we have such high rates of heart disease and diabetes and metabolic diseases among 30-year-old women? That's not healthcare doing that, right? Maybe we start to think about like, why does this country allow so much sugar to be added to all of our food? Why are there so many fast food restaurants all over the place? Why is it so much cheaper to buy Oreos than to buy a bag of apples? Why does our federal government subsidize corn? Maybe then we can start to think about the upstream drivers that are creating so much sickness in this population, net of whatever's going wrong with healthcare.